Hi, everyone. Thank you for joining us this morning on the Big Purple Blob. I am here with a very special guest. First, let me introduce myself. I am Susie Church Brown. I'm a parent and wellness coach, one of the blobbers here on the Big Purple Blob. Today, our very special guest is someone from MED, so the sort of mothership for your health unit at your embassy or consulate. Today, we have with us Dr. Jeffrey Jones. Dr. Jones, would you like to tell us a little bit about your role in MED?
Sure, Susie. Thanks for the invitation. And greetings from Washington, D.C. The sun's coming up. If you can see outside my window, there's a bit of the Kennedy Center sticking out there. So I've been in D.C. since September. I'm a regional medical officer. Is my skill code, I suppose. I'm really a family doctor. That's kind of what I feel the most passionate about. And I'm currently serving in Washington as the Deputy Chief Medical Officer for Clinical Programs. So that role encompasses medical clearances, occupational health and wellness, our medevac program, our laboratory services. Basically anything that touches on patient care is sort of in my realm. But I'm really just a family doctor. It's what I'm most proud of, probably. Thanks for having me.
Well, we love our family doctors and our foreign service health practitioners for sure. So what is so awesome about having Dr. Jones with us today is that he is going to help us kind of dispel some myths about your health unit at your consulate or embassy, and maybe answer some questions about services provided or maybe not provided, as the case may be. And so we have some general topics and questions, but I think we could just let you dive right in.
Great. Thank you. Yeah, I think our goal really, I think, for any service provider overseas should be to have people arrive at post with an expectation of what life will be like there, right? In health units, I'm a little biased because I'm a healthcare professional, but I think medical care is pretty important to most people when they're serving overseas, particularly if you have family members and children who we sometimes consider more vulnerable in the foreign service lifestyle. So, to paint the big picture, so MED is in, the mothership. I love the mothership comment because it's what I say when people say, where are you going next? I'm like, I'm going back to the mothership. So there are 4 categories of direct hires. So the people overseas that are actually employed by the Department of State. They are regional medical officers like myself, and we are family physicians. We are emergency room physicians. We are a couple of med pediatrics, so internal medicine and pediatrics dually trained, maybe a handful of internal medicine docs, but all sort of core primary care people. Like we have one specialist in our department, and that's Dr. Greg Martin. He's our infectious disease guru based here in Washington, and he's the one who helps us understand all the infectious disease threats around the world. But primarily we are regional medical officers. There's 60 of us, and we are all sort of trained in primary care function. We have 120 folks that we call medical providers, that you'll see that term overseas a lot. If they're not an RMO and they're a caregiver, that's a direct hire. They're either a physician assistant or a nurse practitioner. And we combine them both into calling them both medical providers. And those are people that have had extensive training in clinical work as well. But, sometimes varied backgrounds. Some of them may have focused in pediatrics, or they may have worked in an emergency room or in a family medicine clinic with people like myself. Those are the 2 biggest groups. We have 23 regional medical officer psychiatrists, or RMOPs, as they are called. And you can see when 60 RMOs and 23 RMOPs, the regions that RMOPs cover are going to be significantly larger. We're all regional, meaning we may live at one post, but cover many, many in the region contiguously. So the 4th category that probably people know the least about is our regional medical lab scientists, and there are a dozen of them. So huge regions, but they are the ones who are laboratory experts that help us either manage labs in health units that we hit those that have them, or assess services locally to say, I'm going to go to this local blood bank and see what their processes are and say, yeah, I wouldn't, unless someone is at imminent risk of death, I wouldn't go use this blood bank. So super valuable information. They help us track infections and, run the tests that we can do in the health unit and find services locally, as well as do services here in Washington. So those are the 4 people that you will encounter overseas. Now, some posts have all of them. They're co-located. So I just came from Jakarta, where I was for 4 years. We had me, we have a medical provider, we had an RMOP, and we had a lab scientist, all based in Jakarta, but serving a much wider region. There are posts, and this is where I think the expectations are hard to manage in some cases, is because I was in a health unit with 16 people. Our post had 600 Americans. I served in New Delhi and Kabul, which were both also very large embassies. So you tend to have more staff in the health units where there's more Americans to take care of. Our mission, and I should have started with this because I'm a big mission guy. Like, our mission is to safeguard and promote the health and well-being of America's diplomatic community. And what it means is we are there to serve U.S. government personnel. We do not take care of expat Americans, which some people think that we do. I have neither the responsibility nor the authority to do that, except in a rare case if the chief of mission says, Joff, this is an emergency, you need to take care of this foreign dignitary or whatever, then I would step in and do that. But Americans living overseas, which is, an embassy's main function is to support Americans overseas. We don't have the ability to care for them. We do support consular services sometimes in American citizen services if they have a case that they need some help with that's medically related. We'll sometimes give guidance, but direct care is not something we do for them. And so, you go from a large health unit with 15 or 16 people. Obviously, there's 4 direct hires. There's EFM providers, which are a godsend if you're at a post where there's a nurse or a PA or nurse practitioner or a physician, and you can hire them to sort of add a force multiplier. That's huge. But we would depend on local staff, right? Our local staff, as with any mission, are the backbone of what we do. So we have
Mhm.
local employed nurses, admin staff, lab technicians, and physicians. So there are posts. We have 270 posts, I think, and growing by the day in the Pacific Islands and what have you. But there are posts with no health unit. We have 200 health units total, and way more posts than that. So there are posts that we provide support to that don't have a health unit at all, and those are usually with maybe a small amount of American presence. We also have posts where there's a nurse managed, so there's a locally employed nurse, and they run a health unit. So there are posts with a physician, a locally employed physician only. So the services provided really depends on the sort of the resources that your health unit has. So we say yes, we are primary care focused, which some people think, oh, I'm going to go overseas, and if I need an orthopedist, the health unit will be my orthopedist. It's like, no, I can place a cast, but if you need complicated care, it's going to be with a specialist, either on the local economy, or we are going to evacuate you to an appropriate level of care somewhere else. But so a nurse, managed posts can provide vaccinations, they can provide referrals, but their work is really limited by their training. And a nurse is not a provider, so we have very strict policies and procedures. And if you're a 1-person health unit or a 15-person health unit, the rules are still the same. So smaller posts will be supported by the regional medical officer with travel. They go to that post, they see people, but they really manage a lot of it virtually. So the nurse will report to a regional medical officer for their clinical supervision. And so you may be at a place where everything can be done. You can get a pap smear, you can get shots. I can sew up lacerations and help people with most urgent type of needs. And then you may have a post where either there's no health unit, so we're going to guide you how to get care locally, or a nurse will do sort of follow clinical practice guidelines, do what they can, and then sort of call for backup and say, okay, this is what I have, where do we send them? So all of the regional staff's jobs includes assessing local healthcare, and I think that's one of the biggest deficits we've had. Is I think a lot of people go to post and they don't really actually know what the local healthcare is going to be like. We publish these handbooks that cover that extensively for every post, and I appreciate the fact that PCSs are busy times and people are like, yeah, I'll get to that later. We do them electronically now. We don't print paper copies anymore, but it really covers all that. What vaccines you need. We do endeavor to provide all the shots that people need, because it's variably, a variable quality and accessibility on the local economy. So vaccinations is a huge part of what we do. And a nurse managed post would be able to do all of that, for sure. Now, we encounter the same supply chain issues everyone else does, right? You may order something and a year later, you're like, where's your shot? Because cold chain is a bear to manage. But really, we want to be the first place that people go to for healthcare. I think another misperception may be that people are required to use health units. People have all sorts of reasons they don't want to come in and see us, right? And as somebody who practiced primary care for 20 plus years in the US, I'm used to being the good guy. Like I see, my patients usually see me as I'm Dr. Jones is the guy who's going to help me. And I realized when I took my first trip to India as a new RMO, was like, oh, like not everybody loves med. Not everybody loves the health unit. What's up with that, And I realized, oh, the medical clearance thing, right? Medical clearance is like diplomatic security. I think people have this view sometimes that we're there to kick you out of post. We're going to yank your medical clearances. We're going to pull your security clearance and get you kicked off the job. It's certainly not our goal at all. But while people, have full rights to use the health unit, they don't have to. And some people in well-resourced posts just say, I'm going to get my care locally just because it's of great quality. We're fine with that. We'll help point you in that direction. The only thing we ask is that you keep us in the loop when things are serious, or there's stuff happening, because ultimately, if you run into an emergency situation and you need to be evacuated, the local healthcare provider can't do that for you. We do that for you, and it's a funded benefit. And it's a lot of what we do in places that don't have great healthcare options. So, it is hard when people are getting care in parallel. As a primary care focused person, I feel like the health unit wants to be your medical home. If for whatever reason that's not your thing, then at least, fill us in on the big stuff so that when we're making decisions about other stuff, there's no kind of like, oh, by the way, I'm on all these meds that I got prescribed locally, because that's dangerous, and I think it's a risk to your health. And so just for the sake of practicing good medicine, we do want to know that. And my job is to go to local providers as a regional medical officer and visit hospitals and say, yeah, this is a reasonable standard of care. We don't have the ability, because foreign countries don't just let us in, to go through their books and look at all their credentialing. We go and visit, and they're usually welcome, happy to let us in, but we ask questions, and we take the answers they give us. And we have experiences, right? We'll go to emergency rooms with patients, and then we can say, yeah, I was in the such and such emergency room with a patient, and they had this experience there, and pass that on to people. So I think if you start with the health unit and you try to pay attention to the material they're giving you, it's a great place to kind of understand when you first get to post what's available, so that there are no surprises when something emergent comes up.
And for the smaller posts that, so we've been super lucky and never been at a post that didn't have a health unit, except for when we were moving into a new embassy in, I think it was Cambodia, and they hadn't opened the health unit. Mm-hmm. You then have like a relationship, I should say, someone has come and set up a relationship with a qualified local entity, right?
Yes, thank you. That we have post medical advisors in many posts. So they're a local physician, and we vet them. We always prefer to connect with people that have had sort of international training, either in the U.S. A lot of foreign physicians have practiced in the U.K., places like that. So they are kind of our eyes and ears on the ground. So in places where there's no health unit, they may often be the first person you contact, and say, call Dr. So-and-so. They will do an assessment. They'll get you the emergency care that you need. And then they will call someone like me or a medical provider to say, I saw this person, here's what's going on. This is what I want to do. Do you concur? And we'll have a conversation. So absolutely, those are vital connections that we have. And even if they're not the ones who can provide the definitive care, they're very well connected to their local community, right? So they will say, oh, this is the hospital I would send them to for this test or this x-ray kind of a study. So yeah, great point. Thanks for reminding me about that.
So a question on the staff. I noticed that, so my kids have basically grown up overseas, and they have done their darndest to basically try and test the skills of all medical providers at all of our posts. So thank you. Hats off to all of you who have helped my kids. But there's not ever a pediatrician on staff.
No, as I mentioned, some of our RMOs, our regional medical officers, will be sort of dual boarded in internal medicine and pediatrics. We have had cases where we've had an EFM pediatrician. In New Delhi, I was lucky enough to work with a local pediatrician that we'd hired. So pediatricians may be on staff, but they won't be a direct hire, because the model that Med has is we have limited numbers of us. And I will say, for the first time in my tenure with Med, which is 8 years now, we basically have filled all of our positions. Medical providers, our PAs and nurse practitioners, have historically been very difficult to fully staff. We have 120 of them, and they serve in some really tough places. So right now we actually are in pretty good shape. But it means that, when you're a lone direct hire, you kind of have to be able to see everyone. Pediatricians, by and large, see kids.
Mhm.
So the majority of people at a post are going to be adults. So it's great to have a direct hire as a pediatrician, but what about the rest of them? We can't put a family medicine person or an internist there with a pediatrician. There's just not enough of us to go around.
Mhm.
So part of the qualification in being a direct hire is you have to actually be able to see the breadth of care, including prenatal patients. I did obstetrics in North Carolina as a family doctor in a rural area, and I loved it. Some of my emergency medicine colleagues are sort of have to get up to speed with, although emergency docs, I think, deliver plenty of babies unintentionally, but we all come from different backgrounds, but the basic standard is that you have to kind of be able to see from babies up to, retirement age. So it's a great question, and we would love to staff every health unit with a pediatrician. It's just not viable, I would
Yeah,
say.
no, totally makes sense. I mean, that financially probably wouldn't be the best
Yeah.
decision.
There was also, I think, people always want to know, well, who can go to the health unit, right? Like, yeah. So if you are a U.S. government employee and you're on temporary duty for under 30 days, and your agency, your sponsoring agency, pays into ICAS. Med is almost entirely ICAS funded as far as health units. The interagency, every agency pays in for their staff. So if you're there at post for under 30 days on a TDY, you do not have to have a medical clearance. Everyone else pretty much does, except active duty military. Their agency, DoD, clears them. Civil service in the military do have to have a clearance. So everyone else needs a medical clearance to be at post for more than 30 days. And that's a process by which we sort of determine, whether the resources you need based on your particular health background are available at that post. And if they're not available, how are we going to get them, arranged for you? So our mandate is really to take care of employees and their EFMs. We have a lot of questions always about members of household, and adult parents of employees can be either EFMs or members of household, depending on how HR does that particular set of orders. But adult parents of employees are never eligible for the health unit access. So they don't have clearances. They may live in housing, but the FAM is basically pretty clear that they're not eligible. And adult children, so once your children turn 18, right? If they're in university, they have access till they're 23. If they're not in university full time, then they have access till they turn 21. There are cases where children are fully dependent on their parents beyond the age of 21, in which case we do a certificate of incapacity. If that child really could not live independently, then they have health unit access. There's insurance issues, of course, that everybody gets kicked off of dental and vision at 22, but we have people here that help to extend that. So we can't take care of your guests when they come in because we can't take care of American citizens outside of the U.S. government health unit. So it's important if you have elderly parents traveling to post or anyone really in a healthcare situation that could be dicey, that they have their own private insurance, including medevac, because you don't want to get into a situation where you need a medevac and then the health unit tells you, sorry, they're not, we're not authorized to medevac your family member because they're not part of the medical program. So it's always a great question, and one I always love to answer before people host travelers than when something happens and then they're shocked to realize that we can't just take care of them in the health unit.
And the traveler's insurance isn't like, we used to purchase it when my mom would visit, and it's not, I mean, it's not pennies, but it's not horribly expensive because
No.
it's usually for a shorter duration of time.
Right, and you're just buying it for that particular trip, and you can adjust the premiums. I mean, we do a lot of air ambulances, and at least we do a lot of pricing in moments when we need a medevac and someone needs that sort of level of support. Vast majority of our medevacs are via commercial airlines, but they can be, I mean, depending on how many stops they have to make to refuel, some of our air ambulances cost $300,000 or more. And if you're a Department of State employee or your agency funds your medevac, it's reassuring to know that's not going to fall on you. But if you're a tourist and your insurance doesn't cover that, that can really add to the price of your vacation.
Yes.
So it's well worth the price of getting the insurance for sure.
Yes.
It's a great point.
No. A couple more questions on health unit functions, and then we can move to medevac because
Yes.
I know everyone has medevac
Yes.
questions. So prescriptions, I'm sure that everyone expects the health unit to provide all of their prescriptions, including those that may or may not need a cold chain. So
Yes. So,
what,
and we want
what,
to, we, yeah, we want to
okay.
do that. And we have different ways to do that. So every health unit, large or small, has a pharmacy, right? And so some of them could be quite extensive depending on the size of your post. Some of them are going to be pretty tiny and stocked with mostly emergency medication. So the role of the pharmacies and health units is really to stock meds that are going to be needed on a short-term acute basis, antibiotics, malaria prophylaxis. Sometimes we stock, um, medications for GI issues that hopefully will resolve eventually, and respiratory issues. Everybody gets, all these viruses overseas. So I think what we struggle to be able to stock just because it's expensive and they expire are some chronic medications like blood pressure medicine, cholesterol, thyroid. We do keep stocks, antidepressants, because we recognize that even the most fastidious employee or family member who's got mail order, sometimes the mail doesn't come on
Mhm.
time, right? And you're getting into that fill. So we do that in different ways. We give you stocks out of the health unit pharmacy, and everything the health unit does is free of charge. I think, which is, as a provider, is like the best part of practicing in med is that I don't bill anything to anybody. And that's the U.S. healthcare system speaking through me, but it is a blessing. We care for patients, and we don't charge them a thing. Now, if you go out locally for tests, we send blood out to local labs, and you buy medications on the local economy. Yes, you're going to pay for that because that's not something the health unit has purchased for you. But if you have a chronic medication, best bet is to make sure that you have mail order privileges, and we don't endorse any particular insurances, but Foreign Service Benefit does cover mail order through Express Scripts. Blue Cross does if you have the standard. If you have basic, it doesn't. So we always encourage people know what you're getting and where you're going. And we can write a prescription. I can write a prescription. I can send it electronically to CVS Caremark or Express Scripts and have them send it to your pouch. So we would do that in terms of writing the prescriptions that you need for long-term medical issues. Absolutely. In a pinch, usually we can help you get them from the health unit. In some countries, we will say, yeah, this pharmacy locally is very good. They carry, FDA quality level stuff, which is not always the case. Many countries manufacture drugs, and I wouldn't touch them with a 10-foot pole. That's the health unit's job to tell you that, right? And so we suss all that in the moment, but sometimes we'll have you get them locally, short-term use. And people are always amazed at how inexpensive pharmaceuticals are in other countries, and it's because of the healthcare system here and the price, the overhead that goes along with that. But cold chain, is always been a hot topic because a lot of the rheumatologic medications for autoimmune disease have always been cold chain. They are remarkably effective. They have revolutionized people's ability to manage some of these conditions. Now we're dealing with all the requests for the weight loss drugs and the diabetes medications, right? Wegovy and um, Ozempic. So the challenge with those is they require refrigeration throughout the transport and when you get them. So we don't have a mechanism, and this is not a med thing so much as it is a bureau and a GSO, right? The admin bureau and a GSO thing. Health units can't order medicines for individuals and have them come through the pouch. We
Mhm.
have cold chain, like some of the things that we get, vaccines mostly, we have to order, and a bureau handles it for us and ships it. But we can't say, John Smith, you need your Ozempic. We can't order that from you through the government system. It's just not, it's not permissible because there's no way to charge your insurance for that, right? Your insurance pays for that stuff. We give you whatever we have out of the health unit totally free. So what we do is we help people figure out creative ways to get around it. Now, a lot of the payers are much more flexible with people that we say, look, please give this person 6 months of medication because they want to pay for 6 months of expensive stuff, right? They want to give you 90 days.
Yep.
And you're like, yeah, but the mail's really unpredictable. So most of the time we win that argument on your behalf. And we're happy to advocate with them, explain the situation. Some people even get a year's worth, which we're always super happy with. And then they find ways. They get special coolers. They can have it sent to somebody in the US who will then sort of figure out how to courier to them, or they just bring a year's worth when they come back from R&R. It's their workarounds right now, but we are compiling a list on a sort of a resource library through clearances as we modernize that process so that we can say to people, yeah, we can't guarantee we can get your med for you, but here's some creative ways to do that. And people are very motivated to do this because these medications are super important to their health. Right now, though, we're having to get creative at finding ways around because some countries it's just really tricky to get anything. DHL and FedEx will not ship your stuff because they can't guarantee that it'll be maintained. If it's
Mhm.
not maintained, it may not be safe, and then you have to trash the whole shipment. So um, we're still working on it, but we've made some good strides, I think, in a positive direction.
And I mean that is probably this question is probably for the clearances portion of this conversation, but
Yes.
that would, if someone is dependent on that sort of medication, then that would be a consideration that they should then think about. Maybe they don't go to Sri Lanka because their medicine
Yeah.
can't come here. And
Yes. And I will, I'm going to say that there's super exciting stuff happening in clearances. And I'm going to just mention it briefly because I promised my communications director I wouldn't get ahead of the ALDACs that are coming. So next week, I believe, I was told, Wednesday, Thursday, and Friday, there will be three separate sort of all hands communications coming to the department. One is about the new medical clearance process. The second is about the new mental health medical clearance process. And the third is about child educational issues. Because Med has been over the past 18 months sort of totally updating how we're doing medical clearances moving forward. Right now, it is involving mostly new hires. So the old way, employees had to be given a worldwide available to be hired by the department. That's no longer the case. So this is all going to be explained in the ALDACs. We know there'll be a flurry of questions, particularly from in-service people saying, well, what about us? You know, class one, class two, all that's disappearing in the future. And so by the fall, those of us that are current employees will also be going through that. The most exciting piece that touches on what you were bringing up, Susie, is something called Medcare management. So we have not done a great job, I think, historically at preparing people for the realities of the post that they've been on. So now when we identify someone through the clearance process as having, you know, not something that previously would have been a class two where we had to evaluate them for each specific post, but saying this person might need some extra support. They might need some extra education because, again, the expectations aren't always what we assume them to be. And people don't know if they're new hires, how would they know what it's like to be overseas in an austere environment? So we are going to assign a Medcare manager, who is usually a nurse or sometimes a physician, to have an in-depth conversation with that employee or family member about their particular issue, to say, here's what, you know, your specialist in the US thinks you need, is saying, you know, you need a mammogram every 6 months. Here's your bid list. Like, these posts, we can do mammograms locally. These posts, we cannot. If you really want to go to this post that doesn't have mammogram availability, we can't medevac you every time you need a mammogram because medevac's a very particular procedural thing for emergencies that can't be handled at post. But maybe you'll say, okay, if Jakarta, for instance, we don't recommend mammograms be done in Jakarta, not because they're not available, but because the quality is not up to US standards. But Singapore is right next door. It's a cheap flight. It's an hour and a half flight. Maybe that employee is going to say, you know what, I'm going to go to Singapore on my own every 6 months and get my mammogram. Jakarta may be great for you, right? In the past, we may have said no because it's not available at your post. So
Mhm.
flexible, you know, sort of less no, more let's get to yes on your clearances, but also ensuring that patients have as much ownership of their own health as possible. Because some people may say, well, if it's not available posts, I'm not paying for anything on my own. Okay, then we're not going to send you to those posts where that's going to be the situation. Some people say absolutely. I mean, we have people now, new hires saying, I will fly myself back to America every month for my chemo. And we're like, okay, well, you know, like, is that realistic? I don't know. You know, if they're willing to try it, do we want to do that? Sure. So it's a whole new world. I'll stop it there because I don't want to jump the gun. But maybe by the time this airs, all the news will be out anyway. But it's very exciting for us. It's been a tremendous amount of work, but I think the foreign service community is really going to be very pleased with this because we're more partners now and collaborators instead of the, you know, you can't go to this post. Medevacs. I know we want to talk about medevacs a bit because I mentioned it before. You know, a medevac is essentially a decision made by the clinician at post when a patient has an issue that's urgent, meaning it cannot be managed during the next R&R or home leave, and it's not available at post. If your provider says, yeah, we can do this here and you don't want to do it there, that's okay. But we're not going to medevac you because you'd rather go to Canada, or something than go to Mexico. It is essentially our foreign programs folks who do the medevacs told me in preparation for this talk, they're like, medevac's just money. It's just money. It's like, well, I think it's more than that, but it's basically an airfare. It's lodging and per diem during your medevac. We have 4 medevac centers. Roughly Dubai is sort of a 5th sometimes, but Bangkok, Singapore, London, and Pretoria. Washington, D.C., of course, is the medevac for all of WHA. And almost all mental health medevacs will come back to the U.S. And that's because of cultural issues. There aren't a lot of places we have good local healthcare for mental health because it's so culturally based. So almost every mental health medevac is going to come back to the U.S. Basically, those are the posts that have U.S. equivalent healthcare that can manage most problems. Now, certain diagnoses, if we think it's a new cancer diagnosis, that will require a long time, or cardiac, sometimes we're like, let's get that person back to the U.S. because they'll be there months and they don't necessarily want to be in Singapore for 3 months, spinning their wheels, be back with family, what have you. So there's a lot of flexibility in that. But many people don't appreciate that the department's opinion about this is rest and recuperation, R&R. It is not rest and relaxation. You're given R&Rs and you are assigned a hardship differential at your post because of the healthcare situation. So if you're at a post that's got 3 R&Rs, the department expects that you're going to do some of your basic healthcare stuff during your R&R. Many people resent that. They say, well, it's my vacation. I'm not going to go home and get a colonoscopy because what fun is that? It's like, well, that's your choice, but we don't medevac for screening colonoscopies, because the expectation is you're given, extra income at places where that's not available locally. Hardship differentials are hugely weighed based on medical capabilities at post. So, we're not going to medevac you for something that you're already being, somewhat funded for and given R&R opportunities to do that. And that is just the way it's always been. And I think it helps to sort of think about that in those terms. Sometimes people say, well, I'm going to go to Bangkok and I'll go to that great private hospital and get my stuff done. That's great, but if it's an emergency and your R&R is not for another month, we're not going to make you wait, and do that. We're going to send you on a medevac. And that's coordinated, through post. We approve them and we do it for all agencies, pay for their own. So state pays for state, USAID pays for USAID, Homeland Security pays for their own people. Med just coordinates all of that. So I think knowing that maybe makes people a little bit less upset when they are told no for medevac, because we really want to do as much as possible, but we have to abide by the FAM just like everyone else in that regard.
People also don't get to pick their medevac point, right? They go to one of the designated points.
Yes and no. Great point. So medevac centers are assigned regionally. So London covers all of Europe, Northern Africa, Pretoria, the rest of the continent. Singapore covers all of EAP. Dubai and or London cover a lot of NEA. And then, the US, we used to have a medevac center in Miami and now we don't, but some medevacs go to Miami. But because of COVID, we have relationships all over the United States now, in San Diego, in New York, that we can medevac people. But there may be a good reason for you personally to go somewhere, and we will always consider a cost construct medevac. So if your medevac center is London, but you have a good reason to go to Vienna, I'm not saying that's a great example, but you would be funded for London. And, if we can approve Vienna, we will certainly do that. So you're going to be funded for the medevac center that's appropriate for you, unless we decide to send you back to the US for a reason. And then we'll fund that to CONUS based on that. So not a lot of choice. People sometimes want to go back to their home country. A medevac will never be approved if the quality of care where we're sending you is worse than the place you're leaving. That's just, for us, it's a no-brainer. It's like a medevac is higher level of care, not somewhere where you have family, where the care is worse potentially than where you're being medevac from. That's never going to happen on, through a medevac officially.
Now I have a few more questions on general medevacs, but for an OB medevac, I have heard of foreign-born spouses going and
Yes.
being with their family in their home country,
Mhm.
whether or not the care is a place that I would have a baby. But
Right, right. Yeah, OB medevacs are special, and we have two amazing consultants who handle those specifically in foreign programs. But Med's official position is we recommend you medevac to the United States at 34 weeks. That is kind of our official. Lots of reasons for that, but the details aren't super important. But going to a post that's not a medevac center is called a post-to-post medevac, and yes, that does happen a lot, and we appreciate the importance of that, particularly in the after the baby's born, right? Having that kind of support of family around is really useful. So we consider those case by case. It will almost never be in a worse place because the accepting RMO basically has to approve that. And if they say, no, like our healthcare here is horrible, like a woman could go there and see a local provider and deliver, but she would not be on a medevac procedure officially.
okay.
Yeah. So Bangkok is very popular, for that reason. And Bangkok's got amazing healthcare. It's kind of one of our alternate medevac sites. So those approvals are pretty easy. We're dealing with one now to Taipei, and we're sort of like, okay, Taipei's better than where they're going, and they speak the language, right? I wouldn't send an American English speaker to Taipei because the health unit can't navigate all that care, and if you don't speak the language, you're going to be in really struggling. But if the pregnant person speaks the language, then obviously that does influence our decision, because they'll have an easier time navigating the healthcare system.
Well, two of mine were born in Singapore, and that was a really positive experience as well.
Yes, a lot of people, most people when I was in Jakarta wanted to medevac to Singapore because it's closer, right? And partners can go see
Hmm.
people than having to go all the way back to the US. So yeah, Singapore is a very popular place for delivery.
So now back to like general medevacs. Can someone be medevac for a chronic problem? You did mention like if someone has like a heart situation, they might be sent to the US. But what about like known chronic medical problems?
If it's an exacerbation. Yeah, if somebody's having something where they needed, catheterization or something, and we wouldn't do it in the country, absolutely. So it doesn't mean that you're stuck with all your chronic stuff. It's not like health insurance, right? Where you have pre-existing conditions. But if it's just your annual stress test that your cardiologist recommends, no, we don't medevac for that. If you need a stress test because you're having chest pain that's not been previously diagnosed, yeah, of course we're going to send you for that. So deteriorations in chronic known conditions absolutely will be considered for medevac. New stuff, we medevac a ton for orthopedics just because fractures happen, and that stuff. But yeah, I mean, we are always trying to figure out a way to make it work. But I think, medevacs are not for convenience, and they're not often done because, of sort of preference in that respect. So yeah, the medevac team works really hard, and we have, I think, moved forward in very positive directions in terms of, the big one we always encounter everywhere is, it's in the FAM, and it's in all of our handbooks that if you come back to the US for R&R, have a colonoscopy, have a pap smear, get a skin thing biopsied, you're supposed to get the results before you go back. And I can't tell you how many times people show up at posts and they're like, hey, I'm back from R&R. I just got my mole biopsy and I have cancer and I can't get it taken care of here. Can you medevac me? And it's like, oh, it's pretty clearly delineated. No, we can't. So what we're doing now is, get your stuff figured out, because you may be eligible for per diem in conjunction with other travel, meaning your R&R orders end, but guess what? Your follow-up isn't till next week. Retroactively, Med will almost always approve those with records that will give you lodging and per diem to sort of fill the gap and then get you back to post. We always want you to get things dealt with in the US, just because we can't guarantee we can deal with it at post, and then it becomes a whole thing, right? But many people aren't thinking about that when they come. So now in many cases we are offering at least the per diem and lodging, and that meaning we can't medevac you with a flight, but if you go on your own, we'll support you with per diem. It's kind of that in between, and then making sure we educate people during the med care management process. Please, like, get stuff figured out. Don't get your pap smear on the last day of your R&R and come back and say, oh, it's abnormal. And, like, if you're a place where you can manage it, great, that's easy. But if you're not, we'll help you find the care. It just may not be eligible for medevac. And that's just, again, the rules are rules, and we are expected to abide by them just like every other bureau.
Our general standard of practice for our family is you're already jet lagged, you're grumpy, so you may as well just do all of your medical appointments right in the beginning, and then you're still
Yes.
there in time for the results come in. So
Yeah,
it's
and it's a pain. I mean, I'll tell you, I practiced in the US in 8 years. I was in North Carolina for many, many years. New Mexico, New York, Michigan. I practiced in all those places, but it's a slog, like I'm a new resident of DC. I grew up next door in Prince George's County, but just navigating the healthcare system here for a physician, it's daunting, right? And we totally understand. We have something new. I'm just going to put a shout out to, it's called Med Connect. It's run out of our exam clinic here for people that are traveling back to the US, not for PCSing. If you're PCSing to the US, we expect you to kind of use your insurance, find your provider, establish. But if you're just here for training, R&R, and you're going to be in the DC area, we will actually help connect you to appointments. We do this already from Post. We have great relationship with George Washington, Georgetown, Inova in Northern Virginia, and your health units can help you do that. But help us help you, in the immortal words of Jerry Maguire or whoever that was in that movie. But um, tell us ahead of time, hey, I'm going on R&R and I'd really love to get a colonoscopy. Can you help me with a referral? Because these are scheduled 3 to 6 months out in the US. You can't land and say, hey, can I go to GW tomorrow? Because the answer we know, like we don't have those kind of magic connections. But those points of contact at those places understand foreign service. We give them your dates ahead of time, and then they come back within a day or so with an appointment for you. And now if you're in DC, our exam clinic will help you to make those appointments and sort of make sure that that information gets back to Post and that you get guidance about what to do with this before you go back if you need to do anything with it. So it's a great service. It's brand new. Health units love it because they have really no visibility when people are in the US on their patients. So we're trying to be that bridge because primary care, when I joined the department, I will say just a plug, I was astounded at not the maybe not the lack of understanding, but longtime foreign service families. There wasn't really an appreciation for primary care, and I've taken care of people for 11 years at a stretch, right? I've taken care of kids I delivered and older folks. It's an incredibly rewarding thing, and our lifestyle makes it really hard to get primary care. We move around, your providers move around, but we are implementing a electronic health record. And it's already started. We are going to be able to connect people the way that they've been used to in the US for so long and get rid of your 20 pounds of family medical records. It's gone live with the clearances part. We expect in the next year or so, patients will actually be able to access their medical record. All of your shots, all that stuff's going to be registered. We are 20 years behind the times in med. We're basically building our own at this point. Most of the commercial products are designed for billing. And there's just a lot of things that aren't useful for med. So we decided to make our own, and it's super exciting. It's happening now with the modernization of clearances. And so I'm shouting it from the rooftops because I get asked this all the time. Why don't you have an electronic health record? Congressmen and senators write to us on behalf of their constituents saying, why don't you guys have an electronic health record? It's like, we know we've had a couple of botched efforts and this is for real and it's already working. But that is going to make care continuity much easier for people and more convenient. And I'll just say another piece about privacy because we get asked this a lot. I think in some places med has a reputation for, people say, well, I'm not going to go to the health unit because they're going to tell everybody my business. 100% honesty, has it happened? Yes. We are human beings. And yes, we've had cases where there have been breaches of patient health information, private health information. We deal with them very seriously. We have a quality management section that I also supervise here. Patient complaints about that are investigated. We remediate people. We counsel employees. I would say right now, without an electronic record, the biggest mistake people make is, we send emails, right? We do a lot of our care via email. I mean, we do a lot of it in some places over WhatsApp, which is like, we shouldn't be doing, right? People used to WhatsApp me in Jakarta on my personal mobile. I have a work phone, personal phone, and start telling me about their medical stuff. And I said, whoa, 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 this is my private phone. Like, I'm not on call, and this is, this is not protected information. So please, please send it to the on-call person, or send it at least to my work mobile where it's, it's somewhat protected. But we take privacy super seriously. We are not, and a lot of people say we violate HIPAA. Med is not a HIPAA covered entity. HIPAA applies to certain services, mostly through insurance, and we don't do insurance. So we do maintain adherence to the Privacy Act, which is similar to HIPAA. But privacy issues, if you experience them, please let us know. I once was at a health unit when I was a new RMO that people told me, they're like, yeah, we don't keep our medical records in the health unit because we don't trust the provider. I was sort of like, oh my gosh, this is a problem.
Wow.
Like, it's a problem, and we addressed it, but please don't assume that my wife knows your business, because it's a joke between the two of us. I practice in a small town in North Carolina. People come up to her all the time and say, hey, I saw Joff and yada yada, and she says, you know what? Like, my husband tells me nothing. Like, if you don't want me to know your stuff, please don't assume that I do. The same thing happens at Post. People come up to you in the restaurant, right, and start talking about their medevac. My wife tells me a lot of stuff that she hears, and I just kind of say, oh, really? I already know all this, right? But she doesn't know that I know because I don't talk about my patients at home. That's true of every provider, every nurse. Like, we don't share your information. Sometimes people get annoyed because they come to the health unit and they're like, why can't you just give my husband my medicine? It's like, if you tell us we can do that, we'll do that. But we don't just give out information because, again, we do maintain privacy. And so be mindful of that when you share. We can't control what our employees and family members tell each other, but we don't. We don't share that information. So please understand we do take it really seriously.
There is a little bit of a fishbowl feeling for embassy community. So it is always nice to hear that you are respecting our privacy, and that is especially, health privacy. That's very important.
Yeah. And I do know, like, when you're a big practice, like, maybe some people say, you know what, Dr. Jones may be a good doctor, but I just don't like him. I don't like his personality, whatever. He's not my cup of tea. You have other choices, right? We realize in health units, sometimes you don't. Our job is to fix the problems. And, we do handle a lot of feedback for providers, and we reprimand them, and we sometimes pull them from posts, because, again, quality matters, and one bad seed can really ruin things for the rest of us that are really working hard to care for our patients. But we do recognize these small communities, you don't often have a lot of choices in health units, and you may not have choices on the outside. So it's unique, but the fishbowl piece is tricky. But yeah, but please don't assume just because it's a small community, everyone knows your stuff. If you tell them, that's your choice. But we're not gonna. We shouldn't tell them.
So we're maybe getting to the end of this super interesting and useful conversation. I just want people to know that we're not going to be talking about mental health topics here, just because while it is a part of med, and I don't know, Dr. Jones, if you want to add more to this, but we feel like it's kind of enough of a topic to cover on its own.
Yes. So I'm an RMO, right? So med intentionally tries to keep medical and mental health separated for privacy reasons. Like, if you see the psychiatrist whose office is next to mine in a place like Jakarta, because we're co-located, I don't have any idea what's going on there, right? And again, those are assumptions, right? Well, if I saw the RMOP, then the RMO must know everything. It's like the RMO doesn't know everything, and that's by design. But what I will say, some of the questions to cover them, RMOPs do prescribe. They do help to manage. They actually do short-term therapy, but there's 23 of them, right? So long-term counseling, if you've ever accessed psychiatry services in the US, mostly they do diagnostics and they do medication. Psychologists, social workers, there's a whole manner of mental health professionals that do long-term counseling. I'm a huge, proponent of Truman Group. I've used them personally. I've referred people to them. That's a virtual counseling service that works with expats specifically. They have providers all over the world to meet time zone stuff. But mental health services here has the child family program. They have the alcohol drug awareness program. They have employee consultation services, which is a huge value for short-term stuff. Been tremendously active during the Gaza-Israel stuff for all of our affected personnel around the world. But mental health manages clearances and medevacs a little differently. than other medevacs and clearances. So, I think my counterparts in the mental health arena would love to address that, because again, I don't want to get it wrong. But yes, RMOPs do all those things, but will they see you for a year? Probably for twice a week or 3 times a week therapy? Probably not. But they can help connect you to that. And yes, they do prescribe just like your other medical folks do. And they medevac in similar ways. As I mentioned before, most mental health medevacs will be to the US, just because we sometimes worry that, we don't want to institutionalize is the wrong word, but if you need to be hospitalized for a psychiatric reason, you definitely do not want to do that overseas. Like the culture of mental health, as many challenges as I see in the US at some marginalized groups getting adequate mental health services in the US, it's far better than it is in other countries where they don't even, acknowledge that mental health is a thing, right? So those services may not be advisable. And so if you need a medevac, you're most likely to come back to the US, particularly the DC area. So mental health is huge. They do an amazing job, but again, a lot of it's about communicating. And so we definitely have work to do on that, but I'm sure they'd love to come and join another Purple blog at some point in the future.
They are most welcome. Dr. Jones, thank you so much for joining us and having this conversation about the important services provided by MED and by the health units worldwide. I would love for you to come back and talk again once the MED clearances information is out there, because I know there'll be a lot of questions, and I think
Yes.
clarity on that. I mean, we have to go from point A to point B, right? And that medical clearance is super important. Personally, I'm really looking forward to not hauling 5 medical folders with me on my person
You and a
as
whole
we
lot
travel.
of people. Yes.
That'll be awesome. So we appreciate that work. But
Well,
thank you
thanks.
again.
Yeah.
Any last words?
No, thanks for the time. I talked a lot and I apologize for that, but I'm excited to be here in Med because we call it, this is where the sausage is made, right? This is where policy is made. This is where those of us overseas have a better understanding of why things are a certain way, and help support our health units. But something we started a little while ago is Ask Med at state.gov. It's kind of the catch-all. There's a ton of email groups for Med specific departments. But if you have a question, you're not sure where it should be directed, if you write to AskMed, ASKMED at state.gov, we will funnel you into the right person. And we welcome those questions. And some of them have stumped us, to be honest, and we love a challenge. So please don't be strangers. We aim to be a partner. We understand we have some work to do in communicating who we are and what we do, but I think it's a really exciting time for Med and the department.
Well, thank you very much for that. And we appreciate all you do. So thanks for listening to the Big Purple Blob today, and we'll see you again next week.